So the video is now recording, and I am going to stop sharing my screen. And Jane, take it away.
Thank you very much, Dane, and welcome everybody. It's a gorgeous day out finally. The sun came out. I'm very happy to welcome you all back to our Brown Bag Lunch program. And this is the first item on our agenda this session. We'll have 11 of them. So you're welcome to come back every week until the end of the session. It's an interesting variety. I try to make it interesting and cover a wide range of topics. Any one of you, by the way, who's interested in doing one in the spring and think you have a specialty you'd like to discuss, feel free to submit a proposal. That proposal form will be on the next newsletter that you can access, or you can look online and it will be available at humboldt.edu/OLLI. So I'm happy to welcome back, they've been here for a number of years in a row, Claire Day, who's Chief Mission and Program Strategy Officer for the Alzheimer's Association of Northern California and the Northern Nevada chapter. She's a clinical social worker and received her degree from Bloomsburg University in 1993. Prior to joining the Alzheimer's Association, she worked in the long-term care field as a patient and family advocate. And Kim is our resident senior community engagement manager for the Alzheimer's Association. She received a BA in journalism from HSU and a master's in science and community health from Austin Peay State University. Welcome to you both. And by the way, they'll tell you this, but if you have questions, you can always put them in the chat. They are going to ask you to ask them, or they will address them at the end. There will be two presentations. Claire will go first and Kim later, and then you can ask questions at the end. But you can always put them in the chat in between, so we make sure they don't get lost. Thank you all for coming, and we'll be chatting with you later. All yours, Claire.
Thank you so much, Jane, and thank you, Dane. Thank you, everybody, for joining today. I'm going to hope that technology works to my advantage, and if someone could just let me know that you're seeing the screen the right way, the correct way. Kim, thank you very much.
It's absolutely correct. Thank you.
Okay, thanks so much, Jane. And thank you for inviting us back to talk about the updates since we were last here last fall. This is information that we pull together from mainly from a large research conference called the Alzheimer's Association International Conference. So today what I'm going to do is, as always, a little bit of level setting, because I do like to just make sure that everybody is on the same page when we start talking about about Alzheimer's and dementia. And I'm going to give you some updates on what we've learned in the last year about early detection, treatment, and risk reduction, including the top-line results from the U.S. Pointer study, which if you were attended in the past, you've heard me talk about that lifestyle clinical trial that has been underway since 2017. So, like always, I do like to start at the beginning with a little bit of level setting, just to make sure we're all on the same page of understanding the difference between Alzheimer's and dementia. And it's really important to do this today because of some of the advances with both early detection and treatment, because unfortunately, they do only impact people who have the biology of Alzheimer's. So dementia, we know, is that umbrella term that really describes the loss of function of enough severity that it's impacting someone's abilities to do their activities of daily living, things like bathing and dressing and going to the grocery store. So it's a collection of symptoms that can include cognitive symptoms, behavioral symptoms, even psychological symptoms. Alzheimer's is the most common type of cause of dementia. So the dementia is the loss of function. What's happening in the brain, that differs from person to person, depending on the type of dementia that they have. And you can see underneath that umbrella, the most common type is the biology of Alzheimer's disease. It's why you hear us talk about it more. Of course, people can have vascular dementia. They can have dementia from Lewy body dementia, frontotemporal degeneration. Different changes of the brain But what they're doing is causing the same symptoms, the loss of function, the cognitive changes, the behavioral changes. So when we look at Alzheimer's under the microscope, as we like to do to really understand it, this is what makes up the biology of Alzheimer's. So it's this buildup of beta amyloid in the brain, these extracellular deposits of beta amyloid, and these intracellular deposits of a protein called tau. Tau is a transport system in our brain, and what happens with brains of Alzheimer's is the beta amyloid accumulates and doesn't clear like it's supposed to, and it sort of forms these deposits around your cells, and the tau protein gets off of its track, think of like a railroad track, and stays where it is instead of moving throughout your brain. And what that ends up doing is sort of creating these tau tangles in the brain. And what that does, you can see here on the right-hand image, is really changes the composition of the brain. You see that shrinkage, you see the change in the actual brain. That's the biology, right? What that causes is the symptoms that we saw on that previous screen. But we've made some real advances when it comes to understanding early detection and diagnosis, specifically for Alzheimer's disease. Now, we're not quite as far along with some of the other types of dementia. And you may have heard me report in the past on a couple of clinical trials that seemed promising around early detection and diagnosis. And I have some updates for you on those. But let's start with a little bit of what do we mean by biomarkers? Well, a biomarker is a biological part of you that shows evidence of a disease, and people are most familiar with biomarkers like blood tests to check your cholesterol level or to check your blood sugar. Those are all biomarkers. Well, we've started to see a new frontier in Alzheimer's detection, diagnosis, and research through the use of biomarkers. We've used for some time an MRI. What MRIs are used for in the world of Alzheimer's is to rule out anything that could be causing dementia symptoms. So perhaps it could show evidence of a stroke or a brain tumor that could be causing the similar symptoms. So it's used to sort of rule out Alzheimer's, but used to detect other things as well. It's also very much being used to track some of the side effects from some of the new treatments and used in a lot of clinical trials. Then about probably 20 years ago now, maybe 15, we saw the first approval of a PET scan for Alzheimer's disease. We saw it first using the scan to measure amyloid. And then we saw the addition of a PET scan to actually measure the tau protein in the brain as well. PET scans are used to aid in diagnosing and treating memory conditions like Alzheimer's disease. They are FDA approved now, which is really great. And in recent years, they have become approved by Medicare to be used in the diagnostic process for Alzheimer's. But we know that PET scans are expensive and not readily available in every community. Same with MRIs. And so science has really looked at how can we use other emerging biomarkers to aid in early detection and diagnosis. Cerebral spinal fluid was one of the first biomarkers outside of those scans that was identified, primarily used in research trials in the early days, but you are able to get a cerebral spinal fluid tap. It's exactly what it sounds like. It's a lumbar puncture that extrapolates the cerebral spinal fluid and can detect whether or not there's amyloid in that fluid. But in recent years, we've seen the emerging markers of using blood tests that can indicate the presence of Alzheimer's markers. And the exciting part about that is that there's the potential to use these down the road years before we see any symptoms emerge. Today, they're really being prescribed by a doctor, and they're being used with other clinical diagnostic processes to aid in diagnosis of Alzheimer's disease, but it's a really exciting frontier when we think about the future of early detection and the future of early intervention, maybe before we even see some of those cognitive symptoms. Not quite there yet, but it is exciting to think about. And then we've got these other things like the use of skin or saliva to indicate early biological changes in the brain, even retinal images. Nothing yet far enough along to really report out on, but it's really interesting to think of how they're looking at other ways of examining for these emerging biomarkers that would be low cost, accessible, a lot more places than potentially PET scans or MRIs would be, and would show those early signs of the biological changes before we potentially even see the cognitive changes. Because if we go back a second just to this earlier slide, what we're seeing here, these plaques and tangles, are present in the brain up to 20 years before we ever start to see this part, these cognitive symptoms. So you can have the biology of some of these diseases without having the dementia associated with it. And so what we need to do is get to a place where we have effective treatments that can impact the progression of the disease so that those cognitive symptoms never appear. Wouldn't that be great? Again, we're not quite there yet, but this is the direction that we're headed. And certainly early detection and diagnosis is a huge part of that. Breaking down those barriers and stigmas around early detection would be also a really integral part of how we then would test for the markers of a disease before you actually see the symptoms of the disease. And I equate it similarly to something like pre-diabetes. You can have from your blood test, you can get an indicator that your blood sugar is starting to go on the higher side, right? That they put you in that warning of pre-diabetic prior to you actually having diabetes. Think of the future of Alzheimer's in a similar way, where in that case, you don't always feel the symptoms of diabetes. You don't maybe notice any changes in your blood sugar yourself, but the marker tells you that it's there. And so that's sort of the future of where we hope to go with Alzheimer's disease. And then what we hope is that science also starts to give us similar predictors for other types of dementia, like Lewy body and frontotemporal degeneration. So I want to spend a minute just talking about some of these blood biomarkers, because we really have seen some progress in the last year around these blood tests. So these blood tests are important to know that they are designed to aid in early detection and diagnosis of the disease. So you'll see on that limitation side of the slide, they're not a standalone diagnostic tool yet. They should be used with a full clinical evaluation as well as cognitive testing, because they're getting good, and we've seen those advances of some of the tests that I talked about in clinical trial that were sort of showing this 90 to 95% accuracy, but they're not quite good enough to be used as a standalone diagnostic test. And what these tests are testing for is the pathology of both the amyloid beta as well as that tau protein. And the benefits, of course, these are non-invasive, although some people would argue whether or not a blood draw is non-invasive. But we know, compared to something like a cerebrospinal fluid or even a PET scan that's expensive and can be sometimes overwhelming for people, blood tests are non-invasive alternatives. They enable earlier intervention and monitoring, and they're improving accessibility in primary care settings. And when I think about how do we ensure the future that people have access to getting some of these treatments and access to some of these diagnostic processes, it's not going to be through some of these more invasive tests. They're just not going to be readily available in all communities. So exciting to see. These are making some really good measures. They measure the concentration of phosphorylated tau, it's called p-tau 217 is the tau that they're marking. And they're looking for elevated levels of this p-tau 217, which is an indication of Alzheimer's disease. And so these results are able to show us whether or not there's tau, or in the case of some of the other tests, they're looking at the amyloid. So there are different measures to see both the p-tau and the beta amyloid in the brain. So very exciting to see. These are approved by the FDA. They should be covered by Medicare if you are in need of one, and they would be used for someone who's symptomatic, having cognitive symptoms, and aiding in the diagnostic evaluation, including a clinical evaluation and cognitive testing today. So that leads me into talking a little bit more about where we've come with treatments in the last year. If you've attended this presentation before, you've seen this slide. It's a very, very busy slide. I recognize that, but it shows you the depth of our FDA-approved therapies specifically for Alzheimer's. Again, no such drugs exist today for the other related types of dementia like Lewy body or frontotemporal degeneration. We know that the ones in the yellow, those earlier ones are there to treat the symptoms of cognition and function. So the first three, Aricept, Exelon, Razidine, they're our acetylcholinesterase inhibitors. They're really treating just the cognition and function symptoms. They're not addressing the underlying biology of the disease, but they've been used for many, many years, as you can see here, anywhere from 96 to 2001. They're all the same drug. They're just made by 3 different people, and they're basically designed to do the same thing. In 2003, we saw the addition of the glutamate modulator called memantine, or Namenda is its brand name. Namenda, what makes it different is it's working on a different part of the brain, and it's designed for moderate to late stage Alzheimer's. So whereas you would add Aricept, Exelon, or Razidine in this sort of early stage of Alzheimer's, you wouldn't add the Namenda until moderate to later stage. And then oftentimes patients stay on the acetylcholinesterase inhibitor. And so in 2014, they made a 1-dose combination of both Aricept and Namenda together. This was designed to help caregivers in ensuring that they had less medications to give, make it a little bit easier for patients that might be having trouble taking medications. We also saw in 2020 and 2023 the addition of 2 existing treatments for mood and behavior. One is for sleep, one is for behavioral expressions, approved to be safe in the Alzheimer's disease population. So they're not new drugs by any means, but they had been tested for the first time in the Alzheimer's population. So a little bit of good news for caregivers there who might be dealing with some of these symptoms. But then, of course, the new people in town, the new game in town was the ones you see here in purple, which are what we call our monoclonal antibodies. These are infusions that are used in mild dementia and even mild cognitive impairment. So you have those initial symptoms of cognitive decline, you have the biology of the disease, but in mild cognitive impairment, we see people functioning very, very highly. And you will see that any of the clinical trial results from those 2 treatments, from those 3 interventions, all had the best data in the earliest possible stage of the disease, which is why, again, early detection is so important. Well, Aduhelm was the first one out of the gate. It had some mixed reviews that only met its secondary endpoints. And so it is no longer available. The makers of aducanumab are no longer producing that infusion. But in 2023 and 2024, we saw two new monoclonal antibodies, lecanemab and donanemab, approved by the FDA. And what I wanted to share with you is some advances in both of those treatments in what we call open label extensions. So once a clinical trial ends usually at the 18-month mark, patients that are enrolled in that clinical trial have the option to opt into what's called an open label extension. And so at that point, every group, so in a clinical trial, people are either given the treatment or they're given a placebo. And at that point of the open label extension, every group is offered the treatment. That's important to note because for planning purposes, it means that your placebo group ends at that 18-month mark. But what the makers of lecanemab were able to do through their trial called Clarity AD was continue out that open label extension. And they were able to assume a placebo line based on existing data of people that are not receiving treatment. So overall, what they found was that people that were on lecanemab are on a different trajectory to those not receiving the treatment. What was also good news was that the largest risk factor for these monoclonal antibodies is called something called ARIA, or amyloid-related imaging abnormality. And it's not great. It's essentially bleeding on the brain. While it is a risk factor, it's certainly monitored well throughout the transition of taking the treatments. But what was really important to see in these extensions, these 48-month reviews, is that the risk of ARIA does not become a large factor after the first 6 months on the treatment. That's good to know because I think that ARIA is one of the biggest hesitations that people have in taking some of these treatments. Now, it's also worth noting that people can have these brain bleeds and not notice them, and they monitor for them very carefully throughout the treatment of these monoclonal antibodies. But it's an important thing for people to be aware of. And what they found was at that 48-month mark, 69% of patients did not decline at all over that last 48-month period. And I've given this presentation 3 times, and every time I say to myself, you got to fix that typo in the last bullet, and I still haven't done it. So I want to show you what this looks like on a actual chart. So you see here that the blue line at the top, this is the patients that were originally enrolled in the Leqembi or the lecanemab trial and were in the original control group. So they stayed on the drug the whole time. Now, remember I said that at this point, the 18-month mark, we lose our placebo group, right? We lose our placebo because at that point, participants are offered the opportunity to get into the trial, right? If the trial is positive, they're offered the opportunity to actually get the treatment at that point. So what they did in this case was they used 2 data sets called which are represented here by these purple and pink lines. One is just imaging results from something called the Alzheimer's Disease Neuroimaging Initiative. These are people that are not on any treatment that just consent to getting scans over a certain amount of time so that we can start to monitor scans, right? And monitor the progression of Alzheimer's. They used another set called BioFinder, which is a European equivalent of ADNI, the Alzheimer's Disease Neuroimaging Initiative. And you can see here, both of those lines stay almost the same until right down here. So they were able to essentially create what a placebo could look like. And you can see here the original placebo, which is this blue line here. I know it's really hard to see, but it's this blue line here, stops at the 18-month mark, but you can see that it's on the same trajectory as these other 2 lines, which is where the scientists feel they have pretty good equation of what a placebo could look like if they had continued out the placebo. And this is what they mean by people that are on Leqembi are on a different trajectory than those that are not taking the treatment. So you can see there is a significant difference there between the two lines here. So this is again reporting at 48-month data. This is all people that are still enrolled in those clinical trials, and so you can see these aren't necessarily stopping. It's not plateauing the clinical decline, but it's certainly making an impact on higher functioning. Now, what happens at the 18-month mark for people that are getting these monoclonal antibodies is they are then eligible to get what's called a maintenance dose. So at that point, they stop the sort of regular infusions, which are every 2 weeks, and they go to a maintenance dose, which varies on the amount of time that it's usually then only monthly. They don't have to go quite so often. Well, the FDA just last week approved a subcutaneous dose of the maintenance dosing. So this would be now weekly, but in at-home injections, which is really good to know for people that don't live close to some of these infusion sites. So patients would have had to have gone through the initial 18-month infusions where they still go to the infusion centers because these aren't pills, these treatments. But after that 18-month, they would be eligible to get the subcutaneous maintenance dose at home if they wanted to. And what's exciting is Leqembi is also testing a full subcutaneous treatment that's in clinical trial as we speak. We don't have any results of that yet. So the other monoclonal antibody that is still currently being prescribed is called donanemab. So donanemab has not been on the market quite as long. So this is only 36-month data. So this is their 3-year data. And again, we're seeing similar benefits. So they're growing benefit over 3 years in that early symptomatic Alzheimer's disease population. The early initiation of donanemab reduced the risk of progression to the next stage of the disease by 27% on what's called the clinical dementia rating global scale. It's a universal scale that they used. And what's different between donanemab and lecanemab is donanemab presets an amount of amyloid clearing. And so once, let's say it's 18 months that they want you on the treatment for 18 months, some as little as 12 months. What we saw was that they're able to actually stop the infusions at that point. And so we saw here that more than 75% of the participants reached that amyloid clearance within 76 weeks of starting the treatment. And so this is giving us the potential that you can stop the infusions once the amyloid is cleared. And so a lot of question then about, well, what happens? Does that mean that the amyloid comes back? I don't think that we have a clear answer to that yet, but it is encouraging to know that there's the potential for these treatments to have a shorter term use rather than have to be something that you're on for a longer period of time. So that's sort of the update on where we are with treatments for Alzheimer's disease. Again, we don't have any updates for anything around frontotemporal degeneration or Lewy body disease because there's just not enough clinical trials yet that have any evidence to show that there's any treatments for those diseases, but there are lots in clinical trials. So we're hoping in the years to come that there may be some good news in that front as well. So I'm going to switch gears for the rest of the presentation and talk a little bit about risk reduction and specifically some new updates on what we've learned about risk reduction. We know that there are things about risk that we can't change. We call those our non-modifiable risk factors, things like age, race or ethnicity, our gender, genetics, all play a role in our risk of cognitive decline or dementia. And we can't change those things. But there's this great amount of stuff on the left-hand side of the screen here that has had, over the years, some really good evidence to show that these types of modifiable risk factors may impact our risk of cognitive decline or lower our risk of cognitive decline. Now, it's important to state that we know that this is not the answer, right? We know that just making these lifestyle changes or leading a healthier lifestyle does not eliminate the potential to get Alzheimer's or dementia. But we do see the evidence to show that there is growing evidence that doing these things can certainly help as we age, and certainly even help people that have the early signs of Alzheimer's to function better over time with some of these lifestyle changes. So we saw a few new reports this year from AAIC around modifiable risk factors. The first was one that really looked at a decades-old problem of lead and lead pollution. And this was a study that looked at some of those historic levels of lead air pollution that had the potential for memory problems 50 years later. So they looked at more than 600,000 adults who were linked to some of this exposure in their early years. They grew up in areas that had extremely moderate to extremely high atmospheric lead levels, or and sort of in that key time, 1960 to 1974, they were associated with 20% more likely to report memory problems after the age of 50. So we know that that's a lot of why we don't have lead paint anymore. We don't have leaded gasoline anymore, that there has been a long time connection to lead exposure not being healthy for us. But now we have this connection to potentially making it more vulnerable for age-related diseases like Alzheimer's disease. So not as fun of a report, right? Because again, I think some of these things are things that we had no control over at the time. It's like some of the environmental reports leading to air pollution. We can't always change where we live, but it's just interesting historical data to look at as well. Now, the next study looked at actually people who had one copy of the APOE4 gene, and what they found was, looking at people that had one copy of the APOE4 gene, those that walked, we know that the APOE4 is the strongest known genetic risk factor for what we call late onset Alzheimer's. That means after the age of 65. People who had a copy of that gene who walked, sort of regularly, had like a good amount of walking in their lifestyle, it seemed to have some protective benefit for them, and even had benefit for, it made their risk less than what people who had no copies of the APOE4 gene had. It had a even greater protection for African Americans, and it also had a good benefit for for females. And so we know, again, African Americans are more likely to develop Alzheimer's, and females are more, these were particularly white females, but still women are at higher risk. So when we talk about some of the risk reduction strategies that I'm going to go into next, it's why we're looking at not just aerobic exercise. We're looking at all of these other things as well. And so whether you have the gene or not, you probably don't know if you have the gene, but if you have the gene or not, walking is good for us. And so that was sort of the takeaway from this study in particular. But one of the highlights for me for the AAIC this year was the top line results from the US Pointer study. the U.S. Pointer Study, or the U.S. Study to Protect Brain Health Through Lifestyle Intervention to Reduce Risk, is something that I've been involved with since 2017, as Northern California is one of 5 sites that participated in this study. So what we set out to learn was really an answer to some of the growing challenge. We know dementia rates are rising and prevention is more important than ever. We know that lifestyle and risk can play a factor. We've seen individual studies that look at nutrition, that look at physical activity, and we know that sometimes having poor nutrition or a lack of physical activity are linked to a higher risk of cognitive decline. If you were here last year, you may recall I reported on the presence of ultra-processed foods and ultra-processed and processed red meats, putting you at an advanced risk. And of course, we know that a sedentary lifestyle has the potential for increasing our risk as well. And some of our early findings have studied these individually, and they've shown some promise. So what we looked to set out to do in the U.S. Pointer Study was shift our focus to see whether or not combining multiple lifestyle changes can better protect our health. So we pulled together 5 sites across the United States: Northern California, Houston, Chicago, North Carolina, and New England, Rhode Island. And we looked for people who were at risk for cognitive decline but did not have dementia, from the ages of 60 to 79, those that would admit to not exercising regularly, and who had what we called a suboptimal diet. And we used a diet called the MIND diet and the score from a MIND diet to evaluate that. We also looked for people that were a little bit older. So it was, if you had 2 or more of the following, you were even more likely to get enrolled in this trial. So we didn't want too many people young. We wanted to see all ages. And so we looked for people that were 70 and older. You had to have 2 or more of the following of these: African American, Native American, or Hispanic. We wanted to ensure that we had good representation. A family history of memory impairment. Now, we specifically didn't call out Alzheimer's or a diagnosis, because if you think of people at ages 60 to 79, their parents might have had dementia, but we might not have diagnosed it as dementia 30 or 40 years ago. So we didn't want that to be something that limited people in being enrolled. And then we looked for people who had those cardiovascular health risks as well: high blood pressure, diabetes, pre-diabetic, high cholesterol. We ended up enrolling 2,111 older adults from diverse groups. We saw more female than male, which is not surprising, but we did have a pretty good mix of race and ethnicity, as you can see here. And then what we did was we took these 2,111 people, and they literally, at randomization, pressed a button and were randomized into one of 2 groups: a structured intervention or a self-guided intervention that would focus on these 4 intervention components: physical exercise, cognitive and social activities, health monitoring, and nutrition. So what did we do? For our self-guided group, they were given education and general support. And I know that this is really small. I've got to make this a little bit better. They met with they had a navigator. They met as a team. They were randomized and put into teams 6 times over the 2 years. They were given healthy lifestyle education, tangible tools to facilitate self-guided plans, general support to encourage physical activity, a healthy diet, cognitive and social stimulation. And like everybody got the same health monitoring around blood pressure and their labs at their clinic visits. Everybody got the same lab visits or clinic visits, compared to our structured group, who you can see here a big difference. They met 38 times with their team over the 2 years, and they had a very regimented role of onboarding the participants through these 4 components. We would spend about 12 weeks at a time going over, no, I'm sorry, 4 weeks at a time. That didn't sound right. 4 weeks at a time going over each of the components. So we started with physical exercise. We got 4 weeks of teaching aerobic, resistance, strength, and balance, primarily at working with them on how to integrate this into their routine. Then we kept up the physical exercise and then added nutrition. So then they'd spend the next 4 weeks focusing on nutrition, keeping up with their physical exercise. Then the next weeks we added, or 4 weeks, we added in the cognitive and social challenges. And then again, like everybody, they got the same health monitoring. Now, the difference there is we really did talk more about blood pressure, and we took blood pressure measures pretty regularly in the structured arm of the intervention. So what was the prescription for this structured group? Well, you can see here, the pointer prescription that we taught was, again, based into these 4 categories. For aerobic exercise, we asked them to do 4 days a week, 30 to 35-minute sessions each session. But we also added in resistance training 2 days a week, 15 to 20-minute sessions, and stretching and balancing 2 days a week, 10 to 15 sessions. Now, if you attended last year, you may recall that I talked about a study called the EXERT trial. The EXERT trial looked at the difference between aerobic exercise and stretching, balance, and resistance training in people with mild cognitive impairment. And so in that particular trial, we tried to compare whether or not one was better than the other. And what we found was both groups after 12 months showed no cognitive changes. These were people with mild cognitive impairment. So that's why it was really important to us to add in both the resistance and the stretching and balancing, as well as the aerobic. Now, the perfect prescription would be to do all 3, but we recognize that older adults, especially if you're going up to, almost 80 years old, aerobic exercise may not be safe for everybody. And so adding in the resistance and the stretching and balance training was really, really important for us to add into their pointer prescription. We use the MIND diet. Again, MIND is a combination of both the Mediterranean and the DASH diet. So things that you would think of like dark green leafy vegetables and things that are omega-3 fatty acids, lean proteins, a lot of berries, nuts, legumes, those sorts of things. And we wanted an average score of 9.5, it's out of 14, or higher. That was the goal for their weekly MIND diet score. We used something called Brain HQ for cognitive and social challenges. And the goal was to do 3 times a week, 15 to 20 minutes. And then they had labs at the same rate as the self-guided intervention group had as well. And so we measured cognitive function over the 2 years every 6 months. So they had cognitive function and testing, which involved memory and other thinking tests at baseline, at 6 months, at 12 months, 18 months, and 24 months. Now, the only thing we measured for the self-guided group was average attendance. So we really wanted them to keep coming back to these 6 meetings. It was a chance for them to check in with their team. It was a chance for them to check in with their navigator, and then given a little bit of education along the way in their 2-year journey. And the goal was for an average attendance to be about 80% for both groups. And you'll see here, the structured intervention team, the average attendance was 94.8%, which is really amazing to think that these self-guided participants kept coming back to these meetings, even though they were only meeting 6 times a year. Whereas the structured intervention team, their average attendance was about 91%. Remember, 38 meetings versus 6 meetings. So not surprising that theirs was a little lower, but well above the goal of the study. For the structured intervention, because attendance was the only thing we measured for self-guided, for the structured intervention, they were all given a Fitbit, so a wearable device to measure their activity, as well as they were given a membership to the YMCA or a gym, not necessarily the Y, but that was our main partner. Their average number of very active Fitbit minutes for the week, the goal was 90, and they reached 86. That was sort of the average across all 5 sites. But then you can see how well they did with the Mind diet. The average was 11 out of 14 points, as opposed to the goal of 9.5 points out of 14. And then the other thing we measured was their activity on Brain HQ. Now, in the first 6 months, participants logged into the cognitive training program for about 23 to 24 weeks on average. However, on the last 6 months of the program, you can see that dropped off a little bit. That they only logged on about 13 out of the 24 weeks. And you can see when they looked at their average levels that they completed. So imagine it's like a game, and you have to complete levels every week. We were completing about an average of 22 sessions in the first 6 months and only 1 session in the last 6 months. I can tell you anecdotally, the participants did not love Brain HQ. They found it to be frustrating at times, and some of them just didn't like the games. Those that really got into it, though, they really enjoyed it. And so I think the big takeaway for me for the cognitive training is really around finding something to do that you really enjoy doing. You want it to challenge you, and I think that was sometimes where the conflict came in with our participants, was that it was challenging, but sometimes it was that challenging piece that frustrated them. So you want to find that balance, that it's challenging enough, but you're still not that frustrated that you keep doing it. Because I think what we saw was that people that got too frustrated just didn't do it at all. And so something is always better than nothing. So what did all of this accomplish? What did we find from doing this clinical trial? Well, we found that cognitive function improved over time for both groups, which is great news. Now, we do think that some of this could be improvement likely due to the practice, right? They take the same clinical tests every 6 months. And so there is something to say that some of that improvement might be them getting used to doing the clinical testing. But we saw specifically that the structured intervention, the higher intensity intervention, had a greater benefit on global cognition than the self-guided low intensity intervention. The primary comparison was difference between intervention groups and annual rate of change in global cognitive function. And that was assessed by these sort of measures of executive function, episodic memory, and processing speed over 2 years. So there was a statistical significance between the 2 interventions, that the more structured group, based on models of normal cognitive aging, performed at a level comparable to adults who were 1 to 2 years younger. And that could increase resilience against cognitive decline over time. Now, what was really interesting was that this extra benefit was the same, regardless of gender, age, or APOE4 genotype, and compared to their heart health at the start of the study. So even people that maybe had higher cholesterol, higher blood pressure, they performed this, they had as much benefit. So what this shows us is that making these lifestyle changes can have impact over time. We know, though, that making changes to our lifestyle are the hardest to make. And so it's not surprising that the structured intervention group did better over time. So this is sort of the recipe that we created based on the outcomes. These are only top line findings. So the last participant finished their 24-month visit in May of 2025. We reported these out in July, at the end of July 2025. So we really only had the chance to look at some of that top line data, and now we'll start to go back in and uncover some of the other little benefits and nuggets that we might be able to find from the data. Participants, the main study is over. Participants can opt to stay in something called the alumni extension. We will follow them for 4 more years if they're interested. No intervention, only doing annual cognitive assessments. But it really helps us then to think about, where do we go from here? How do we then design a healthcare and community program that is available in all communities, that probably starts a lot younger than the age of 60, and think about some of these public health interventions and changes. We've funded 10 organizations to come up with how they're going to replicate or use the study results to create programs in their community, so we can try and figure out what's sustainable and what's not. And of course, a lot of this was built on the amazing work that was done through the Worldwide Fingers Study. The Worldwide Fingers Study started with this lovely woman here on the right-hand side of your screen. Her name is Dr. Mia Kivipelto. She was the principal investigator for what was called the Finger Trial. That was the trial that started it all. It was done in Finland. It was a lifestyle intervention trial and had great similar results several years ago. The difference between the Finger Trial and what we did was that the Finger Trial had no self-guided arm. So they used a structured intervention compared to the normal standard care received for older adults in Finland. We obviously made some changes there for a couple of reasons. One is we didn't have what they call a control group. We had 2 interventions that we tested. Now, the reason we did that here is because we know that the standard care is not equal across all older adults. In fact, even in our trial, some participants enrolled didn't have a primary care physician at the time that they enrolled in the study. And so it would have put other people at a disadvantage if that was the comparison. And so that's why we decided to do 2 interventions. But you can see here now we have 71 countries that are planning, participating, or have completed similar multi-domain non-pharmacologic risk reduction interventions, more than 20,000 participants across the world. So it's really exciting to see. We've long talked about our 10 healthy habits for brain health. And it's you can see here a lot of those components that we included in the US Pointer trial, because we believe that up to 40% of dementia cases could be delayed or prevented by targeting some of these modifiable risk factors. And know that we're always here to help. Should you have questions, want to attend other educational programs, or interested in getting involved in clinical trials yourself, you can learn more about those at Trial Match, which is our sort of matching service for clinical trials specific to dementia only. We recently launched this year something called My All's Journey, which is an app that is to support and guide and connect newly diagnosed people and care partners all in one app. So if you are interested in learning more about that and like being on the phones and involved with the apps, you can get this free mobile app in both the App Store through Apple as well as on Google Play for those who have an Android. And before we go to questions, I'm going to stop here and I'm going to turn it over to my dear colleague, Kim, who's going to provide a little update of her own on how you can get involved with the association. And then we'll come back together at the end for any questions that people might have if time allows. So Kim, I'll turn it over to you.
All right, and get my screen. All right, you guys can see that? or not? Okay, it's up there. Correct, Claire?
Yes.
Okay, all right, I'm trying to see. All right, the little buttons down here to advance the slide. Let's see, why isn't it? Nope, I don't want to do that. Why does it say listening? Okay, I'm not sure. Do you see that on the bottom?
Yep, and advanced.
Okay, but it's okay. It's for some reason it is saying all the words. Are you guys seeing all the words that I'm talking about right now? I don't know why that's going on. Okay, I will just start up here. So Claire, thank you for giving us a wonderful research update. So the research is partially funded by folks participating in our signature activity, which is the Walk Into Alzheimer's, which is coming up here soon. So the Alzheimer's Association walked into Alzheimer's. This started in 1989. It was branded, then it was called the Memory Walk. And in its first 9 years, it raised $150,000. So 34 years later, we just hit a major milestone last year, raising $100 million. So this will be the 10th walk for Humboldt County, which is amazing. So we have a lot of fun activities planned this year to celebrate this milestone event. The Walk to End Alzheimer's, it's the largest fundraiser for Alzheimer's care, support, and research. It's a great way to connect with others that are impacted by this disease and make a difference in your community. Folks are always just amazed when they come out to it, and especially folks that have dementia and their caregivers. They're just amazed to see the community coming together to help support this event. So because you walk, as Claire mentioned, we're in a new era of treatment with FDA-approved drugs that can change disease progression in the early stages of Alzheimer's disease. With your support, we are empowering and mobilizing our community to give all people access to early diagnosis, treatment, quality care throughout their journey. Because you walk, we are fueling critical progress in dementia science. And this is an impressive stat, which Claire probably already mentioned. We're investing in over 1,000 active best-of-field research projects in 53 countries. So I often get, well, does the money stay here in Humboldt County? Well, it really does. It stays all over the world. So if you guys want a cure, we have to do research. And I don't care if the cure is found in another country, as long as, we can all benefit from it. So we partner with clinicians to track outcomes of new treatments to improve the future of care. We just started doing that. We have current and future treatments. We'll offer those facing Alzheimer's more time with the folks they love. So how often do you hear, if I just had one more day with my loved ones? So, and thank goodness these treatments are giving us more days with our loved ones. So a friend of mine, her daughter-in-law, has a mom in the Bay Area who has dementia, and she got on one of the new treatments, and 6 months later went for a checkup, and the doctor was just shocked. She thought the doctor assumed that her speech would be gone, and just the opposite. So she was complete sentences, whereas before she couldn't get out more than a few words at a time. So, and we continue to fight for a future where treatments are accessible to all people facing Alzheimer's and all dementias. So we just don't want it for the wealthy. Everyone should be able to access these treatments. So, so this is our walk. It's coming up on Saturday, October 11th. So it's a little less than a month away. It's going to be at the Dorney Center. Folks check in at 9 a.m. and then they wander around for about an hour and a half. Check out the advocacy table, our education, different sponsor tables. As you see, we've got a pet area. Dogs are definitely allowed. Then we have our opening ceremonies at 10:30. Those go for half an hour. And then we get out and walk at 11 o'clock. And the walk is symbolic. It's a mile walk for the first part of the walk, and then you can continue on for 2 more miles if you want to. So folks ask me all the time, I'm not mobile, or if I don't want to do the walk, that's okay. We still want you to show up. But as Claire told you, walking is super important. So the walking is a good part of the event. We have a fundraising app. As Claire mentioned with the other apps, this makes it so easy to participate in this event. So you can download this free app. You can start or join a team. You can update your personal page, check your fundraising progress, send fundraising messages, you can deposit checks on it, plant a virtual promise garden with our 4 different flowers, depending on your relationship to the disease, and access support. So easy to do this. You can visit alz.org/Humboldt Walk, or you can scan the QR code that's on the screen here. So, and I know folks, some of our folks are still confused about the QR code, and the easiest thing I tell people is basically the QR code is just by scanning it, you're going to the website. So that's all it is. All right, I'm going to end there and we'll get back to questions with Claire. Yeah, let me stop sharing here.
Yeah, so there was one question in the chat that talked about related dementias, other forms of dementia. So there are currently funded, I would say anywhere between 100 and 150 clinical trials, not just funded by the Alzheimer's Association, but funded by the NIH and other private funders that are looking at some of those related dementias. We just don't have any results on them yet. So it's a good question. And then there was another question about the Alzheimer's research that's been impacted. Yeah, so there, one good thing is that we think that right now the NIH's budget for research is intact, which means that they will have as much money that they had last year. There are certainly researchers who have lost funding, and it may be because they have pulled some of the funding for other things, and so we're trying to keep our finger on that and understand. And if you've ever participated in the walk, you probably get our emails where it might ask you to contact members of Congress if there's something coming up that's impacting cost or impacting research, because we're sort of not backing down with making sure that we're advocating to ensure that this money stays intact for the research. Part of the reason we've made so much progress in the last 10 years is because the investment has increased exponentially over the last 10 to 15 years compared to where it was sort of stagnant for many, many decades. And so we can't afford to lose that momentum. And so believe me, we're keeping our eye on that and making sure that where we can advocate to keep some of that funding. One of the things that we saw in sort of some of the early days was that funding was cut and then given back, and sort of the one researcher thought they were going to lose the end of they have a large multi-year grant, and they thought they were going to lose somewhere in the amount of $5 to $10 million in funding, which would have essentially shut down. And so advocates went to work both at that research site as well as the Alzheimer's Association and other organizations, and it was that money was magically restored to their budget. So we're hopeful that we're going to keep as much of it intact as we can. I'll absolutely, Jane, send you copies of the slides. And then the next question was about, can you participate in a study before being diagnosed with Alzheimer's? Yes, there are lots of studies that look at caregiving, that look at the needs of caregivers, that look at healthy aging. And so oftentimes we need subjects who don't have cognitive decline as well. So if you're interested, absolutely take advantage of that. And then the question about the availability of the test to evaluate biomarkers. I can send some information in the slides with the slides, Jane, and then you can send them out with the slides. Is that okay?
Yes, it is.
Yeah. I mean, I
Thank
would
you.
say easily the best thing to do is ALZ.org. We have positions on and information on treatments and all of those things. I would say, make sure that you're talking to your healthcare provider about some of these tests and some of the treatments if you're interested, because there's a lot of misinformation out there, but there's a lot of good information as well.
And then Claire, they're asking again, is there resources where we can find out about available studies? So Trial Match that Claire mentioned earlier. And there's the Brain Health Registry. I'm part of that. So every few months I will get an email from them saying, hey, will you play these brain games? And then, it doesn't take very much time. And then I'll get a score. Thank goodness my score has been fine and stayed the same. But so I think, yeah, she put those in the chat now. So.
Yeah. So the question about the Medicare wellness, part of your Medicare wellness check, which you should be doing every year with your primary care physician, does include cognitive testing and a cognitive evaluation. I would say that it is probably being done inconsistently across the country. It's one of the things that we're working on, trying to arm specifically primary care physicians with the tools that they would need to do a more comprehensive. I'm sorry, the little bug just almost flew in my mouth. Comprehensive evaluation on a regular basis, so that sorry, now the bug is flying all over me. I've got like a little gnat or something around. Sorry about that. Yeah, so somebody asked about, are there any magic pills that we can take or buy to help? I wish that was the answer. I would say if you see ads for supplements and things that are designed to improve your cognition, be a savvy consumer. The thing with those supplements and those types of treatments that are available is they're not regulated by the FDA, so they don't undergo any sort of rigorous clinical trials to show whether or not they have any evidence. Some of them can also, some of these supplements and even vitamins, we always recommend, even if you hear about just taking a multivitamin, to check with your healthcare professional, because some of them are really can interfere with maybe other medications that you might be on for other things like iron or like statins, things like that. So just always, even though it seems like it's over the counter, please be a savvy consumer and check with either your healthcare professional or, a good person to ask is your pharmacist. One thing we always recommend with pharmacists is to use the same pharmacy. Get to know that pharmacist, because and don't go to multiple pharmacies for different medications, because they're the keeper to see all the different medications that you might be given by different physicians, like a specialist from your primary care that may not know that you're on another medication. I also always recommend that people take either a list of their prescriptions if you're on more than one pill, or even take the bottles to your healthcare visits. So if you have a doctor's appointment, take those medications with you, so that because I don't know about you, but my doctor always asks me if I'm on anything else that he hasn't prescribed. And sometimes I can't always remember the names of all of them. And so sometimes I'll either take a picture of all the bottles, or just sometimes put the bottles in a Ziploc bag and take them with me. So really important things. Yeah, someone's asking about the supplements. I mean, we're not really investigating. I will say we did some advocacy, which now has led to if you see the Prevagen ads, and have a magnifying glass and can pause the TV, you'll be able to see at the very bottom of the screen now they have to actually put a disclaimer, which was not there 5 years ago, but through different advocacy organizations, we all sort of banded together to require that that happens. You may have heard me say it, my 86-year-old father lives with me, so we watch a lot of Jeopardy, and Judge Judy, but don't judge us for watching Judge Judy. But if you think about the audience for those TV shows, I mean, that Prevagen ad is probably every other ad that we see on the TV, and there's just no evidence to show that they have any benefit at all. So be a savvy consumer. I don't see any more questions.
When I mentioned Brain HQ,
Oh, yes. So Brain HQ is what we used in Pointer. That was the cognitive testing that we used in the Pointer study. So people had a love-hate relationship with it, but that's because we were forcing them to do it on a regular basis. So it is a great training. It does have a little bit of a cost to it, but there are other things that also have similar benefits. So I think the main thing with any of those cognitive games, and I would say the same is true for exercise, is you've got to enjoy doing it. You've got to like doing it. So Kim and I agree to disagree on what we like to do for exercise. I like to go for walks. I don't mind walking even long distances. I do not want to do a marathon, a 50K through the woods. Is that what you did? Yeah.
Yes.
So she and I are going to agree to disagree on different types of exercise that work for us. But I like walking. She likes running through the woods. So that's why she does it. That's why I do what I do. And so if you're going to stick with it, you got to love what you're doing. And the same thing's true for puzzles. Some people like crossword puzzles. Some people like the math ones. I just discovered if you do any of the New York Times games like Wordle or Strands, I just discovered one called Pips, Pips. And it's basically like dominoes that you have to fit into like a crossword puzzle. And I actually thought I was going to hate it because A, I hate crossword puzzles, and B, I don't like math, but I actually quite enjoy it. So I try to do that one every day. Those little games too, if you don't have Brain HQ, or don't have a lot of time, even just taking a few minutes every morning to do those sorts of things, they really keep your brain working the way that it's supposed to. I don't see any
one
more.
of the things that's interesting is that the discussion that a lot of people do crossword puzzles because, they think it's going to keep their brain active. It does, but what it does is make you very good at crossword puzzles, not necessarily transferable to something else. So if you want to improve your memory, then you need to do things that add memory. Also, if you want to add brain, learning new things, learning
Yeah.
languages. And I want to point out that we're not just talking about foreign languages. You might want to study physics. You might want to start those are all new languages, words and concepts that so you don't have to study Russian or Spanish or things like that. All these areas that you've never studied before teach you a new language, and doing the same old thing all over again doesn't add synapses to your brain.
Well, and it's why partnering with OLLI is so important too, right? Because you're offering those classes and you're offering that ability for people to do something and learn something new. It's such a great example of leading the way. Because it's never too late to learn something new. At least that's what they tell me.
Now, traveling is actually really good for people because it stimulates new learning about new countries. It gets you out exercising. It requires socializing, and it's got tremendous benefit. Go do something different that you don't know. Don't be afraid to do that. Just do it. It's fun. It's exciting. We've got a lot of good OLLI classes, and I encourage you to do that. I'm doing one on sleep, and in that context, you'll learn about the lymphatic system, which is what removes the amyloid from your brain. If you don't sleep well during those first 2 deep stages of sleep, your brain doesn't drain out that amyloid, and it accumulates and becomes plaque. And that's why you need to understand things like that, why getting good sleep is so important. Get it, and what stages of sleep do for you. So get educated. I mean, I love during COVID, we had all this time at home. There were all these series on email that I could access on the internet on mitochondria, oral mitochondria, fatigue, all these things. And there's a series of experts from all over the world brought together to talk about a subject. They don't cost that much. And if you catch it early on, then it's free. You can watch each day's series for free, and then you can buy the whole thing if you want. But you can watch the whole series initially, and they're typically 7 to 9 days old. And they're wonderful. So be curious, be ready to adventure. Like I'm now trying to learn everything I can learn as quickly as possible about AI. Okay. It's fascinating. It's going to change our world. We have a brown bag lunch. Where is it? Artificial on October 27th, artificial intelligence in your pocket. Meet ChatGPT, Gemini, and Claude. And they're more than that. Okay. We have a course with OLLI on AI, and Ross worked for 40 years, starting out with developing the whole concepts and the algorithms. And we are now being run by algorithms, whether we prefer to
Like it or not.
So it's really important to understand what they're doing and how they affect you. And I feel very sorry for young people who can't get an interview because the computer has dumped them out using the algorithm that they have that's based on past performance of people. So it's exciting to learn what's going on in the world. And we encourage you at OLLI to do that. On September 22nd, our next program coming up is on World War II, Los Alamos, and its impact today. What was it like to live then in New Mexico, where the world's first atomic bomb was built? What were the considerations that went into using the bomb on Hiroshima and Nagasaki? How often did the use of the bomb influence nuclear policy after the war? The author will bring alive that momentous period and discuss its impact on nuclear proliferation. Now, if you ever wake up in the middle of the night and you turn on you go to channel 136, there are a ton of really good documentaries. They just had one recently on this whole process of what went on in developing the nuclear bomb and the decisions to use it. So there's so many sources where you can follow your interests or develop new ones. Anyway, any other questions for our wonderful participants here? We haven't put you to sleep yet, Ken? I saw that big yawn. Anyway, any other questions? Okay, Tom. I assist my 90-year-old with all her medical appointments. I learned that people with Alzheimer's do not have their medical chart labeled with AD. So every time I bring her to a doctor, they expect her to be able to accurately answer questions. Has the Alzheimer's Association ever tried to get the medical industry to appropriately label charts to aid in medical issues? There you go.
You know, I don't know that we've ever talked about that, but I'm gonna bring that one to my health systems team. For years there was talk around, what about in hospitals, whether or not there should be a way to indicate, but HIPAA plays a role in a lot of those decisions, to sort of have different colored bracelets and things like that mean you're at risk for something. But let me take that to our health systems team and see if Cheryl has any information there. I can bring it back to Jane.
Sounds good.
Yeah, it's a good.
Any other questions? Well, thank you all for coming, and Kim and Claire, thanks so much for doing this again this year. And I'm sure I'll be asking you to do it again next year because we learned so much in between. And these studies are so important. And if you want to be involved in a study, contact Kim or Claire and contact the Alzheimer's Association and see what's going on around here. Oh, Janina, that's cool. I didn't know you could do that. She had her clapping hands moving across my screen. How do you do that? That's fun. Okay, guys.
Thanks, everybody.
Oh, that's cool too. How do you do that, Dane?
You if you click your React button, the tool button, there should be a list of them. Now I got rocket
Okay.
ships.
All right, there's Claire's going up.
Yay.
There's joy. It's all about finding joy in your life. And this is one good way to do it. Laughter makes the height. Oh, what else do we have? I haven't tried these before.
Oh boy.
We can see, we just all learned something new. We're gonna have a good time. All right, guys.
Thanks,
We'll see you
everybody.
next week. Thank you so much.
Bye.
And
Take
I will
care.
now end the recording.